Hi doctors, I am Dr. Swati Solanki and I am here to explain the topic Leukoplakia. So Leukoplakia is derived from a Greek word leuko and plakia. Leuko means white and plakia is a patch. So any white patch in the oral cavity may be Leukoplakia, okay? Then it is defined as any white patch on mucosa which cannot be rubbed or scraped off and which cannot be attributed to any other diagnosable disease. So Leukoplakia would be first of all white. Second, you will not be able to rub off or scrape it off with any instrument. And third, you will not be able to diagnose it as any disease. So if you see any white patch, you are not able to scrub it off or remove it, and also you are not able to diagnose it. There are no signs or symptoms indicated towards the disease, then it is most likely Leukoplakia. Also, what is the definition by WHO? That it is a whitish patch or plaque that cannot be characterized clinically or pathologically as any other disease and which is not associated with any other physical chemical causative agent except the use of tobacco. So the patient will also give you the history of tobacco. Okay, so these are the four major points. First, a white patch. Second, no rub off or scrape off, you will not be able to do that. And third would be you will not be able to diagnose it. And fourth would be there will be the use of tobacco. Patient को बहुत आदत होगी tobacco की, okay, in any form. Then the why white color? The white color of mucosa is a result of the thickened surface of keratin layer. So यहाँ पे keratin layer का बहुत ज़्यादा buildup हो जाता है which creates a white color, okay. So now here we are with the classification of Leukoplakia, and there are various bases on which we can classify it. First is on the basis of etiology, then histology, extent, clinically, risk of cancer, and by the scientist Benoxy. On the basis of etiology, there are tobacco-induced and non-tobacco-induced. Then histology, dysplastic and non-dysplastic. Here you will see the abnormal growth of the cell, and here growth will be normal, okay. Then on the basis of extent, it is localized and diffused. On the basis of lesion, कि कहाँ पे lesion है, here the lesion is localized and here it may be on many parts of the mouth, okay. Then clinically, there is non-homogeneous and homogeneous. In homogeneous, the lesion will be completely white in color. And these are also on the basis of appearance, 4 types: flat, corrugated, pumous-like and wrinkled. Here is the appearance mentioned, okay. And in non-homogeneous, this is also on the basis of appearance. Here mostly with the white color you can also see the red areas. So in nodular there will be white specks and nodules present on the erythematous base. Erythematous means red base, okay. And verrucous may slow growing papillary proliferations above the mucosal surface which may be heavily keratinized. So this is all about the appearance, okay. So you have to learn all these. Then in the risk of cancer, there can be high risk, low risk and intermediate. High risk would be on floor of mouth, ventral surface of the tongue and soft palate. Low risk would be on the dorsum of the tongue and hard palate. And intermediate will be on the all other remaining side. Then by the scientist Benoxy, Leukoplakia is classified into Leukoplakia simplex, erosive and verrucosa. So these are also on the basis of the appearance, okay. So here uniform raised plaque varying in size with regular edges. So lesion would be uniform, varied in size with regular edges, and it is mostly similar to the homogeneous type of Leukoplakia. And in erosive, it is slightly raised, rounded, and red and white lesions would be present. This means growth, okay. Excrescence means growth that may be described as granules or nodules. So the growth will be like red, granules or nodules which are rounded and red or white. Then here verrucosa means rough. So rough proliferation raised above the mucosal surface will be Leukoplakia verrucosa, okay. Okay, so let's now learn about the etiology of Leukoplakia. So there are 2 types of factors, local and systemic one. Local are 5. Tobacco, alcohol, sanguinaria, chronic irritation, galvanism and candidiasis. And systemic factors are vitamin deficiency, nutritional deficiency, drugs, hormones, syphilis and xerostomia. All these are explained in details in the next slide, okay. And third one is idiopathic or cryptogenic Leukoplakia. So in few cases no underlying cause is identified. They are termed as idiopathic or cryptogenic Leukoplakia. So if you are not able to identify any factor, whether it is local or systemic, and you couldn't find any reason why leukoplakia is present in the patient, then it may be termed as idiopathic. Okay, and these types of lesion have higher potential of malignant transformation. That means transforming into cancer. Okay, so let us learn about the first factor now, tobacco. So tobacco is dry leaves of Nicotiana tabacum, and there are two forms of tobacco: smokeless and smoking. So this is chewable in snuff, and this is cigarette pipe, BD and cigar. Though now smokeless contains chemicals like nitroso, non-nicotine, nicotine, pyridine, picoline, and collidine, plus alkaline snuff act as irritant, altering mucosa and causing damage, forming sublethal cell injury in deep oral epithelium, inducing concomitant epithelial hyperplasia. This leads to tobacco pouch keratosis, not true leukoplakia. So what happens is कि in smokeless tobacco, these chemicals, the pH of the mouth is near neutral, okay, and this pH is alkaline, so obviously this will irritate the mucosa. So after irritation, mucosa alters and cause damage. Overall damage is done to the cell, which causing the sublethal cell injury in the deep oral epithelium, and this induces hyperplasia of the epithelium. Okay, so smokeless tobacco often leads to tobacco pouch keratosis, not true leukoplakia. Then in smoking, chemicals like polycyclic hydrocarbons, beta naphthalene, nitrous amines, carbon monoxide, nicotine, and chemical produce heat which irritate and alters the tissue. Initial signs are redness and stippling of the mucosa. Stippling means presence of a texture then in the mucosa, then forming white and red striations, and tissue surface appears swollen, lastly precipitate with circumscribed configuration. Striations are caused by increased capillary perforation and keratin formation. So basically, how does this factor cause leukoplakia? Tobacco. This is the major factor that causes leukoplakia. So people consume it into either two forms, smokeless or smoking. So both of these contains chemicals which in one or the other way irritate the mucosa. So this have different chemicals, this has different chemicals, but overall both are causing the leukoplakia. Okay, so what is the next is alcohol. It causes irritation and burning sensation of oral mucosa when applied locally, and it also facilitates the entry of carcinogen into the exposed cell and thus alter the oral epithelium and metabolism. Okay, then sanguinaria is a herbal extract in toothpaste and mouth rinse. It causes true leukoplakia and more commonly seen in maxillary vestibule and alveolar mucosa. Then what is chronic irritation? How does this cause leukoplakia? So chronic irritation may be due to malocclusion, ill-fitting denture, sharp broken teeth, hot spicy food, or root piece, etc. present in the tooth, present in the mouth. Okay, so usual site where leukoplakia occurs are the buccal mucosa and less often over the alveolar ridge. Then intense irritation induce surface epithelium to produce and retain keratin, and this is how leukoplakia occurs. Okay, and here leukoplakia is a protective reaction of the traumatized mucosa against the chronic irritation. So, but nowadays it has been observed that maximum lesion due to mechanical irritation are frictional keratosis with very low precancerous potential. Okay, then candidiasis is a type of infection. It also causes leukoplakia, reported very frequently in association with leukoplakia, commonly nodular type. And candidal leukoplakia may associate with tobacco smoking, denture wearing, or occlusion flexion. And tobacco smoking may result in candidal colonization because of increased keratinization, reduced salivary IgA concentration of the repressed PMNL function. These are polymorphonuclear leukocyte. Okay, then electromagnetic reaction or galvanism. So generation of current due to difference in the electric potential of two dissimilar metals. In case of restorations in the mouth, this happens. Okay, so in case of two types of restoration where two metals are present, okay, different, so may arise in the mouth between dissimilar, opposing, or adjacent metallic restoration. Patient complains of metallic taste, persistent pain, even neuralgic pain due to chronic inflamed mucosa. So these mucosal changes may promote malignant transformation of the leukoplakia. So these are all the local factors. You don't need to write all these in the exams. These are only for the, you know, general knowledge. So in the exam you have to only write the main points: sanguinary, alcohol, chronic irritation. These five. This is enough. Okay. So in the next slide, these are the systemic factors. So first is syphilis. So it is a predisposing factor for leukoplakia. Okay. So what does this mean? That people who are suffering from syphilis have more chances to be uh, get leukoplakia. Okay. So white patches seen on the tongue in the tertiary syphilis, and spirochete, the pathogen of syphilis, has predilection towards mobile tissue of the tongue involved in the secondary stage of syphilis. This leads to diffuse vasculitis, further obliterative endarteritis, causing circulatory deficiency to lingual papilla and atrophy of filiform papilla. So what happens is the spirochete, the pathogen, has predilection towards the mobile tissue of the tongue involved in the secondary stage of syphilis. So diffused vasculitis uh, is happening in this case. So bald smooth lingual surface is seen. Shrinkage of lingual musculature may also cause lingual surface. Loss of protective papilla lead to irritation in the dorsum and leukoplakia, which may be minor or severe, localized or diffused. Leukoplakia may be dysplastic, and carcinoma of the tongue develops leutic glossitis. Then vitamin deficiency produce metaplasia and keratinization of the certain epithelial structure. Okay. Then this is drugs. Then virus, herpes simplex and human papillomavirus. All these are the systemic factors. Then is the clinic. So now here are the clinical features of leukoplakia. So males are affected more than female due to tobacco habit, and sites are anywhere on the oral mucosa, but buccal mucosa and commissures are more commonly involved. What are commissures? Where the upper and lower lip meet. Okay, that point is called that area is called commissure. Then lip lesions are more common in men and tongue lesions in women. Then side depend on the type of tobacco habit. For example, in edentulous patient, alveolar ridge would be involved. Then commissural leukoplakia extend posteriorly from labial commissure. That means where upper and lower lip meet over a distance of about 2 cm in triangular shape. In buccal side, it involves the central zone of the buccal mucosa in molar region and along the occlusal line. In male, commercial involvement occurs more frequently than buccal one, with the later being the commoner site in females. So, in males, commercial involvement is more, and in female, the buccal one will be more. Okay. Then local locations in the descending order of frequency of involvement is given here. So commissures, then buccal mucosa, lips, tongue, palate, alveolar ridge, floor of mouth, soft palate, and gingiva. So it is a descending order. That means this is the area where most commonly leukoplakia is seen, as I mentioned here. Then sublingual keratosis, leukoplakia occurring in floor of mouth and ventral surface of the tongue. Then it is sublingual keratosis. Then Ebbingtide type occur in the floor of mouth and appears similar to the undulations left on the sand by Eddingtide due to loose binding and consequent movement of the mucosa in the floor of mouth. We also studied earlier, this is a type of homogeneous leukoplakia. Okay. Then extent, it may vary from small, well localized, irregular patch to diffuse lesions involving considerable portion of the oral mucosa. So multiple areas involvement are not more common. Okay. Then it means they are much common. It may occur in multiple areas of the mouth. Okay. Then color, it may be white, yellowish white, but with a very heavy use of tobacco lesion, brown in color. Okay. Then surface, often finely wrinkled or shriveled in appearance, but may feel rough on palpation. Then symptoms, patient report a feeling of increased thickness of the mucosa. Those with the ulcerated and nodular type may complain of burning sensation. Then enlarged cervical lymph node may be a single occurrence of the metastasis. Then here are the clinical types of leukoplakia. So first one is a pre-leukoplakia, mild or thin leukoplakia. It is very low grade or very mild reaction of the mucosa, appearing as grayish white but not completely white lesion with a slight lobular pattern. Okay. Then here margin is well demarcated, blended with the edges and normal mucosa, and lesions are very soft and translucent and thin. Then second would be homogeneous thick or leukoplakia simplex. By the scientist Benoxley, we have seen the classification earlier. Okay, so these are 84% of the cases seen among city pipe smokers and betel quid chewers. Then they have no red component, usually white in color but maybe yellowish white or yellow. Then localized lesions of extensive white patches are present, a relatively consistent pattern throughout, sometimes corrugated with a pattern of fine line or wrinkled or papillomatous surface. Then what is the site and margin? They are raised plaque formation consisting of single or group of plaque varying in size with irregular edges. Then second is ulcerated leukoplakia. It is occurs in 13% of the cases. Here red area. This is a heterogeneous. We have seen in classification, which at times exhibit yellow area of fibrin appearing like ulceration white patch at the periphery. Then sometimes pigmentation of varying intensity may appear on the periphery due to heat from smoking. This is a mixed red and white lesion. Okay, then nodular speckled or leukoplakia erosive, which we have all studied all this earlier in the classification, but let's revise it again. So in nodular speckled leukoplakia erosive, with small keratotic nodules scattered over an atrophic patch of oral mucosa. Here, nodule may be pinhead sized or even larger and has a high magnetic potential. Then, in Verrucosa proliferation, that means rough above the mucosal surface, lesion demonstrates sharp and blunt projection which are heavily keratinized. They may be accompanied by homogeneous leukoplakia on other oral mucosal surface. Then what is the proliferative verrucous leukoplakia? Verrucous leukoplakia, which is exophytic with development of multiple keratotic plaque with roughened surface projection. Okay, it has strong female predilection and is present in patients who do not use tobacco. So it can spread and can involve adjacent mucosa and may transform into a lesion that is clinically and microscopically identical to verrucous carcinoma or squamous cell carcinoma. Then erythroleukoplakia, lesion with a red component. Okay, so now here is the staging of leukoplakia. So it is according to the size, clinical aspect, pathological features, and site. And so site is denoted by L, clinical aspect by C, pathological feature by P, and site by S. So if L1 here is mentioned everything, then L1, L2, LX, C1, C2, CX. Okay, then staging. So let's understand it. First of all is size. It is denoted by L. So L1 is anything lesion which is less than 2 cm. Then we will mark it as L1. Size in the range of 2 to 4 cm L2, more than 4 L3, and which is not specified LX. Okay. Then here is the clinical aspect, how the lesion is looking. So if it is homogeneous C1, non-homogeneous C2, and not specified, then CX. Then pathological feature, if there is no dysplasia, that means the cells are normal. Then P1, mild dysplasia, P2, moderate, P3, severe, P4, and not specified for PX. Then site, then if all the sites are included, including the floor of all sites excluding the floor of mouth and tongue. Okay, then S1, floor of mouth and tongue, then S2, and anything that is not specified, S3. So this is how we will classify it into the stage. For example, stage 1 has any L. This means it is irrespective of the size of the lesion. If the lesion is homogeneous and S1, that means it is not on the floor of mouth, not on the tongue, it is homogeneous, and here P1 or P2, it may have dysplasia or mild dysplasia, then it is on the stage 1. Here we can see that it is irrespective of the size. Size doesn't matter in any of the stage. Okay, so if it has if it is homogeneous, then it is in the stage 1. You can understand this from C1, C2, and you can miss and match. Then general rule for staging of leukoplakia: if there is a doubt regarding allotment of the correct LSCP category to the case, lower category should be chosen. This will also be reflected in the stage of grouping. Then in the case of multiple simultaneous leukoplakia, the leukoplakia with the highest L or highest S category should be classified. In cases of multiple biopsies of single leukoplakia or biopsies taken from multiple leukoplakia, highest pathological score of biopsy should be used. Then sharp staging is shape 1 in the earliest lesion, shape 2 localized or diffuse slightly elevated plaque. This is given, okay. Then is diagnosis. So clinically, any white patch with a history of tobacco which is not rubbing off is leukoplakia, but we have to confirm it by lab diagnosis. So in biopsy, hyperorthokeratosis, hyperparakeratosis, acanthosis of epithelium, epithelial dysplasia, liquefaction degeneration, basal cell hyperplasia can be seen, and electron microscopy will show epithelial dysplastic changes. So these are the differential diagnoses that how you will classify, how you will distinguish that whether it is leukoplakia or any other disease. So if it has become dry, then that is lichen planus. In chemical, burn history will be of the burn. In syphilitic mucus patches, other features like split papule or condyloma later may be present. In white sponge nevus occurs soon after the birth. So here it is all given, okay. Then this is a malignant potential of the leukoplakia. Then management, elimination of the etiological factor. You will be able to manage leukoplakia, okay. Eliminate the etiological factor. Then conservative treatment is the vitamin therapy, vitamin A and vitamin E, 13-cis retinoic acid, antioxidant therapy, vitamin A palmitate, statin therapy, vitamin B complex, antibiotic preparation, panthenol, estrogen. Then surgical management is given here. Conventional surgery, cryosurgery, fulguration, electrocautery, electrosurgery, okay. Then is, so this is about the laser. It is light amplification of some stimulated emission of radiation, laser in biopsy, laser peel, ablation, radiation therapy, topical chemotherapy. Here are the guidelines, and so this is done with the leukoplakia. Please do mention any comment or any suggestion that you have in the comment box, okay. Thank you.